So I will be talking about the scapular and glenoid fractures. So this is a patient of mine who presented in clinic about 6 weeks later. She was like 68, workers' comp, delay in the referral, etc. So for this patient, as you can see, you may argue what to do in a 68-year-old with this fracture, which is a delayed presentation. But in my hands, she ended up with surgery, and I'm going to tell you why I did and what are the indications. Actually, if you read stuff, that you find out that a lot of things actually has been written a long time ago. Malgain actually in 1855 wrote a book about the scapular fractures and proximal humerus fractures, so a long time ago. And the pictures you see here are not very much different than the other classifications you will see. I think one thing about the scapular fractures, it's hard to break the scapula because it's very well protected between the muscles and the chest wall and everything. Once the scapula breaks, usually there are associated injuries. As you can see on this image below on the CT scan too, there's a rib fractures and a hemothorax or pneumothorax, which is not uncommon. They can also associate the C-spine injury or associated ipsilateral extremity injuries and head injuries too. There are a bunch of classifications. Some of them are scapular body and involves the whole thing. Some of them involves basically the glenoid part of it. I don't necessarily try to memorize any of them. I think probably they are more relevant for research purposes. Regarding the indications, I'm going to repeat some of this again. So I'm going to start with putting up the indications first. So I'm going to separate from the glenoid and the body. I think in the top part, I think there's more consensus between this green area that you see. When the glenoid fracture can cause instability. Again, this is a little vague term. It's not very objective, but I'm going to tell you a little bit about it. Or the articular step-off. 3-4 millimeters seems to be, again, based on the level 5 evidence, because it's hard to have a large series or randomized studies about the scapular fractures. So on the glenopolar angle, the angulation of the whole glenoid relative to the rest of the scapular body, if it is less than 22, meaning that the glenoid is facing towards the floor. So the glenoid is inclination going down. So regarding the body fractures, lateral offset of 2 centimeters and body angulation of 45 degrees. And if you have, in addition to scapula, there's a clavicle fracture. They are both more than 1 centimeter. Again, most of these numbers comes from Peter Cole, who's from Minnesota, who tried to gather a lot of information based on his experience. It's not necessarily replicated by other authors. I need to tell you that. Although I'm biased that I'm looking for more scapulas to fix. So there are some reasons that you may want to think that about surgery may be a better reason. So sometimes it is the instability. The top left, as you can see, if the anterior inferior part of the glenoid is involved and the humeral head is subluxing or may sublux, this may be a reason. Again, articular step-off, how much you expect. Again, this one is probably not very acceptable in a young patient. So medialization is probably the most controversial one because a lot of patients can't tolerate. You see these patients delayed or they don't want surgery or they are in much worse shape. They are in ICU for a month or so, then they are already healing. You let them be and they come back months later and their shoulder function is not bad. In the long term, is there any consequence? It's hard to know. Then this superior shoulder suspensory complex. If you have multiple injuries and fractures around the shoulder, this may be instability. This is also controversial because there are series that shows that you can get good outcome both ways. Angulation of the body can cause sometimes irritation of the chest wall at the scapulothoracic joint. Again, the glenopolar angle if the glenoid is tilted down. So I think CT with 3D recons is a must to be able to understand this, and you need to get the subtraction of the humeral head. Otherwise, it's hard to see the glenoid en face very easily. Again, these are the kind of the articular step-off is more accepted. As you can see, there are multiple numbers over between 1993 to 2012. The numbers kind of varies between 2 millimeters and it ends up 5, then 4, 3, 4. I think because of the tolerance of this joint, and it's not easy joint to get to and fix it, I think instead of the typical 2 millimeters for most of the joints that we talk about, I think 3-4 millimeters is more kind of relevant for this joint. Again, in a young, healthy patient, if I think that I can improve the joint reduction as other joints, I may recommend surgery. In an elderly patient, I may tolerate a little more. Again, instability that I told you, I think you need to look at how much of the glenoid is involved, and the sports surgeons are more kind of critical about this, how much of it, when it is involved, can cause like a Bankart equivalent, Bony Bankart equivalent. What is a glenoid fracture that needs to be fixed or not to be fixed and let it be in a first-time dislocated? If it's a rim fracture, probably you can, but if it involves a big chunk of the joint or is displaced enough that the proximal humerus, the humeral head, may sublux anterior-inferiorly, then this may be an indication to fix them because of the reasons of instability. This is the glenopolar angle. As you can see, if it starts tilting down more than 22 degrees, again, I'm not sure if these are magical numbers, but these are the cutoff numbers reported in the literature. Or relative lateral border offset of the where the glenohumeral joint compared to the lateral border of the body of the scapula, or the angulation of the scapular body when you look at it in a Y view. This superior shoulder suspensory complex, or the so-called floating shoulder, a lot of times the shoulder is not necessarily floating, but I think you can argue that if we fix in a young, healthy patient, the recovery may be quicker than we try to treat non-surgically. Or there's any subluxation or dislocation scenarios, I think this may be a better argument to fix them. The typical approach for me would be, one of them would be posterior approach, depending on the fracture. So usually, I'm going to show an example. So if the fracture is accessible that I can review and fix it from the posterior approach, I'm going to use a posterior approach. This is a 62-year-old female, right-hand dominant, had a pelvis fracture and other issues, referred 2 weeks post-injury. On the first look, actually, the glenohumeral joint looks like where it's supposed to be. But if you look at on a CT scan, on an axial CT scan, in this 62-year-old young healthy patient, the half of the joint, or maybe 40% of the joint, is displaced. Depending on which cut you view, there's a big step off, probably about 5 millimeters. And this is a CT scan. Actually, there's a significant displacement. You can argue that it's a lower part of the glenoid, and it may not cause any issues, but the displacement was significant enough that I decided to fix it. And she did pretty well. This is a 4.5 months post-op. She got good range of motion. This is another patient, 30-year-old hairstylist, so had to use both hands. Motorcycle crash. As you can see, it's a very comminuted glenoid fracture. In some views, most part of the joint is involved. This is pretty comminuted. In a very young, healthy patient, I think if you let this be, there's a very good chance, high risk that she's going to develop arthritis at some point. The good thing, they don't develop arthritis right away, but I think it's not going to last too long. This was a posterior approach for me that I can access the whole thing. This is a large skin flap, as you can see. This is the traditional Jude approach. You elevate the infraspinatus of the scapula. I don't do this anymore if I can, unless the fracture is very comminuted. In this specific comminuted fracture, I elected to do this full approach to basically reflect the whole infraspinatus. Usually, I try to work through the intervals, which is the modified Jude approach. Again, I fixed with the mini frag plate. At that time, I used that bigger plate. I don't think you need that big plate. I think 2.4, 2.7 plates are good enough, and I don't see that any reason why they would fail, because they don't really usually fail. And at 3 months, there's a pretty good result for the range of motion for somebody young and healthy who's working with their hands. There's another limited posterior approach. Actually, the skin exposure too, you can go even much smaller. This is a patient who's a Coast Guard who didn't want to take time off, and he was moving from one place to another, and he didn't want to delay his care, and he wanted to get back to his physical job sooner. Again, the indication was just the translation of the body. This wasn't involving the glenoid at all. So this is the medial and lateral side of the scapula. You can make incision and fix them. The last one is the deltopectoral approach that everybody is more familiar through the multiple shoulder surgeries. This is a 56-year-old male who fell off the scaffold at work, had multiple injuries, has this inferior part of the glenoid involved, as you can see on the CT scan and the 3D recons, again with subtraction of the proximal humerus. I elected to fix this. I thought that this anterior inferior part of the glenoid will cause instability, and he got this anterior inferior plating. He also had a non-displaced or minimally displaced greater tuberosity fracture that because of I was doing the surgery anyway and I want to move him sooner, I fixed that with a small plate there too. And he did pretty well too, as you can see. Going back to the indications, glenoid fractures that you think that anterior inferior part of the glenoid especially can cause the glenohumeral instability, or the step-off is more than 3-4 millimeters, or the glenopolar angle more than 22 degrees, a little softer indications, or body fractures which has lateral border offset greater than 2 centimeters, or body angulation more than 45 degrees, and if there's a clavicle and scapular fracture at the same time, they are displaced more than 1 centimeter. These are the most recent literature, what they show. Take-home messages. I think you need to look at every fracture because they are all different, and which one is better for an anterior-posterior approach is the surgery is indicated. And I prefer to do a modified Jude or limited approaches if possible, as everything else we are going to less invasive approaches. And if you do a posterior approach, you're going to pay attention to the suprascapular neurovascular bundle and the axillary nerve for the anterior approaches. Thank you.